appraising a screening randomized control trial. I'll use this case scenario to illustrate this. A 58-year-old male presents to OPD for a routine checkup. He has got no comorbidities, does not smoke or drink, is asymptomatic at this point of time. Wants to know if he should undergo screening for colorectal cancer at this point with a flexible sigmoidoscopy. So worldwide, I'm giving a background on this. Worldwide, colorectal cancer is the third most incident and fourth most leading cause for mortality. And flexible sigmoidoscopy has got a 67% sensitivity in picking up either colorectal cancer or a polyp. So I'll be using this article that is published in the Lancet, where they looked at long-term effects of once only flexible sigmoidoscopy in screening on colorectal cancer incidence and mortality. So the difference between a screening test as opposed to a diagnostic test is the fact that you're looking at general population. These are not people with symptoms or any clinical suspicion of a disease. So if using a screening test has to make sense, it should be a disease which has got a significant burden of suffering, has got a preclinical phase so that you can pick it up and make a difference. You have a test that is available which will help you do that. And early treatment should be better than late treatment. So when we look at the structure of a screening test, you're screening the general population. Out of that, you can have a bunch of people that may be normal, or out of the normal, some of them can be true negatives or false negatives. And similarly, if the test comes out positive, that may be false positive or true positive. So there is no established critical appraisal tool to look at the critically appraise a screening randomized control trial. So I have used some questions from the JAMA User's Guide to the Medical Literature Framework, an article published in 1997 on evaluating randomized trials of screening, the CASP checklist, and the McMaster critical review form. So does the question make sense? Is the basic study design valid for a randomized control trial? So they have looked at people who are 55 to 64-year-olds from the general practices in the UK. They were invited to screening with a flexible sigmoidoscopy. The control arm was no screening. The outcomes they looked at were incidence of colorectal cancer and change in mortality, and they followed them up for 21 years. So the inclusion criteria or the criteria to invite them for screening was all patients between 55 to 64 years of age from 14 general practices in the UK. Eligible participants were sent a questionnaire and they were asked, are you interested? So, and they excluded people who could not give consent, people who already had history of colorectal carcinoma, adenomas, or IBD, people with severe or terminal disease, and those who had a life expectancy less than 5 years, or somebody who had had sigmoidoscopy or colonoscopy in the last 3 years. The sample size that they calculated was assuming that 55% of the people who were asked to screening would accept. So was the assignment of participants to interventions randomized? Yes, they were randomized in a 1:2 ratio, and they were stratified by general practice and household and in blocks of 12. There was no allocation concealment. Were all the participants who entered the study accounted for at the conclusion? Yes. So they had screened 3,75,744 patients, of which 7,000 were excluded by the general practitioner. 3,60,000 were sent the invite, of which 1,94,000 had responded yes, and 24,000 were excluded because they did not fulfill they fulfilled exclusion criteria, and 1,70,000 were randomized either into the invited to screening group or the control group. So the thing about the screening test is whatever follows after the screening test follows. If you have picked up something on colonoscopy or flexible sigmoidoscopy, the treatment follows. So the regular practices were continued. So are the results of the study valid? So were the groups similar at the start? So in a screening RCT, we see three columns where this is reported. The first is the control group, and the second one is the invited to screening group. In the invited to screening group, there will be a population that is actually screened, and there is a population that is not screened. We want to know, first of all, if the control group and the invited to screening group are similar, and whether the screened group and the not screened group in the invited to screening group are similar. So in case people who did not undergo screening are not similar to the people who are in the large invited to screening group, that may defeat the point of randomization. So we want to ensure that this screened group is similar to the total invited to screening group, and that and control group have got similar baseline characteristics. Because these are not patients, the factors that we can look at here are whether the uh, uh, gender and the age is evenly matched or not. They seem to be evenly matched. Now, where the outcome assessments blinded to randomization, it is unclear and has not been mentioned separately in the paper. Where the patients analyzed into the groups in which they were randomized, yes. So looking at the overall validity for the randomization part of the screening RCT, the study population was appropriate, the outcomes were well defined, randomization was done, sample size was adequate, the blinding was unclear, intention to treat analysis was done, and the baseline characteristics were reasonably matched. Now coming to the results part. So as this is a screening RCT, the results we will look at based on how relevant the particular test was for the screening and the treatment that followed the test. So the question we will ask as to whether the screening test per se was appropriate are more cases of early disease detected in the screening group. So at the point of it, as it was a one-time screening test, at the point of screening, we are expecting a significant increase in the number of cases that are picked up. So the red line is the bunch of people who had underwent flexible sigmoidoscopy, and the blue line is the people who did not have any intervention. So if we notice, there is a increase in the initial increase in the number of cases that were picked up in the red group, and with time that has come down. So the second question regarding the tests that we want to focus on are fewer cases of advanced disease detected in the screen group. So we will look at the incidence of all site colorectal cancer, the control group, and the invited to screening group. So the number of cases that were picked up in the these are people who got cancer. So was 4,201 in the control group, and in the group that were invited to screening, it is 1,631, which is significantly less. So now regarding the treatment that followed the screening, so has advanced disease been presented in the screening group? So we will look at something called the disease-specific mortality and whether that was lower in the screen group as compared to the control group. So if we look at this table, the we are interested in the colorectal cancer death. So we want to know whether the screening process reduced death due to cancer at the end of 21 years. So the again, we are comparing the control group and the invited to screening group, the total. So 1,329 patients who were in the control group passed away due to colorectal cancer, and the 502 patients in the invalid screening group died. So the absolute risk reduction is 0.003 with a number needed to screen of 336 to prevent one death due to colorectal cancer. Now, why do we use disease-specific mortality to assess this particular effectiveness? The as opposed to a randomized controlled trial of therapy, we are not studying patients in a screening test. We are studying general population. So there are certain biases that can be present in the study design, which we can overcome if we use a disease-specific mortality over case fatality. So one of the such biases is lead time bias. So the whenever you screen somebody, we are picking up a disease which has not really manifested clinically. So if we look at so this is when the test can be picked up on a screening this thing, and this is when we will clinically pick up. Sorry, this is when we clinically pick up the disease. So when we are looking at case fatality, we are assessing somebody from when they become deceased. We are not looking at from the time of randomization. So if we look at case fatality, that may falsely prolong somebody's lifespan and will tell you that your mortality was better because you screened. So, or in the sense that eventually the disease, this may be added to the survival rate if we look at case fatality. There is also a length time bias where patients who may not have had significant clinical problems may be the ones that are picked up when you are screening at that point of time. And that may also falsely show that your test was better. So the next question that we ask is it clear that early detection and treatment produced a net gain? Or what is the effect on all-cause mortality? This particular study did not show a difference in all-cause mortality. And most cancer screening studies have not shown a benefit in reducing all-cause mortality. They decrease disease-specific mortality, but does not have a significant effect on all-cause mortality. This may be because of a harm associated with the procedure as such, or maybe because this is a more hard outcome than disease-specific mortality. This one problem is how do you say that something is a death due to colorectal cancer, and how do you say that it is not? So you may be underreporting the number of deaths due to colorectal cancer. That is a possibility. Second possibility is even if you change outcomes in a specific cancer like colorectal malignancy, how much does that really contribute to overall mortality? So this study may not have been powered, or this study per se may not be powered to pick up a change in all-cause mortality. So as to whether this study definitely showed that this has a benefit in reducing your risk of death due to colorectal cancer. And the next option as to whether he wants to undergo screening will be based on the individual's values and preferences and what is the cost effectiveness. So, thank you.
Thank you, Dr. Appu.